Chest injuries. All right, the national competencies, nothing there really you need to worry about because we're going to drill down into all of it, not just because they're competencies, but because they're things you need to know. Statistically, almost 750,000 emergency department visits from chest trauma. I would imagine this 18,000 deaths is, I don't know what year these stats are from. I would imagine that there are more than 18,000 deaths from chest trauma. The instance of penetrating chest trauma seems to be increasing. We have more and more people shot all the time. It makes the news, national news even. It's like when I was a kid, when you watched the national news at 5:30, whatever time that came on, there was always a body count from the Vietnam War. I was a young kid, but it seems like that's how they kept score in that war, instead of like in World War II, what island was taken or what country was the Axis forces were pushed out of this country and that country. The way I think news was probably reported in World War II, we just had body counts, and he who had the higher body count won. So that's a vivid memory of my childhood. One reason I think I've told you before, my uncle was a Navy corpsman, and he did 2 tours in Vietnam with the Marines. So I was always afraid he was one of those in the killed in action or wounded in action numbers. He was one of the wounded in action. We just didn't know it until after he died in a car wreck a few years after he got back from Vietnam. But now we have the inner city violence, and it's big news and one political faction claims the other's responsible and the other vice versa. So I think who's responsible is the one pulling the gun, pulling the trigger, and maybe the ones who don't do enough to keep the guns off the street. But I could go all day on that. That's not what we're here for. What do we need to do with chest injuries? Well, we have to recognize there's an injured chest, right? We'll talk. Some things are very obvious. Other things are not as obvious. You have to know what you're looking for and be aggressive in treating it. Immediately treat injuries that interfere with normal breathing function. That doesn't just apply to chest trauma, that applies to everything. But chest trauma can quickly lead to respiratory distress, and then quickly from there to respiratory failure. We're not able to fix everything. Trauma is a surgical disease. You've heard me say that 73 times now, maybe 74. But trauma is a surgical disease. So what is our role in that? Recognition, rapid transport, providing the supportive care that we can during that rapid transport. And I would add to that, always transporting to the nearest appropriate facility. And you'll have protocols that dictate what that rapid transport is. I will tell you that there are places that require transport to the nearest hospital. And it could be that you could engage helicopter and they could fly right over that nearest facility and get your patient to to a trauma center so that a trauma surgeon or general surgeon, whatever they have on staff, but so that a surgeon can get your patient to the OR, open their chest and repair what's going on inside. Here's an interesting number. I think each hemithorax, H-E-M-I, that means half or one side of, each half the chest can hold up to 1.5 liters of blood in an adult. So if we say that the average adult has 6 liters of blood, that represents 25% of total circulating volume of blood. If you happen to have an injury that involves both sides of the chest, that's half. This bleeding can occur quickly. You have great vessels that run through the mediastinum, and depending on the trajectory of penetrating trauma or the degree of blunt force trauma, you could easily involve both sides of the chest or involve just the great vessels in the mediastinum, and that mediastinum can also hold a significant amount of blood if you have great vessel involvement. Let's say blunt force trauma with shearing forces causes an aortic tear. We may call those patients dead on the scene. That patient may be DRT, dead right there. We can't put the aorta back together. If we had a thoracic surgeon, cardiothoracic surgeon right there ready to go, they might be able to crack a chest in the field and do a temporary repair until they could get the patient to the hospital to actually do a graft and repair the damaged vessel. That does happen a little bit in Europe. How is Europe different than the US? All kinds of ways, but pre-hospital medicine wise, in several of the European countries, you have physicians, sometimes surgeons, surgical residents who are on ambulances, and they respond to scenes. And I've seen pictures of the aftermath of a chest being cracked on a sidewalk in Germany, and with an explanation that that patient was saved because there was a surgeon immediately available who could treat that. Geographically, we're very spread out in the U.S. As a general rule, we don't put physicians on ambulances. We depend on EMTs and paramedics to provide stabilizing treatment and transport the patient. I guess there's decent arguments both ways. If you're staying here in the U.S., the point is probably mute. Even on a helicopter, you're not going to have a physician on that helicopter. Remember, there's a difference in ventilation and oxygenation. Ventilation, air goes in and out, right? And blood goes round and around. That's not ventilation. Air goes in and out. Oxygenation is employing diffusion in those capillary beds in the alveoli to oxygenate the blood that's circulating. There's no reason to go on. Started to go into something else. There's no reason to do that. You know where the thorax is. You know what's contained within the chest cavity. Important things. Very large veins, very large arteries in the chest. If you have an injury involving the superior vena cava, if it's very significant, your patient may have a hemothorax, and they, despite your best efforts, there may be nothing you can do. Aortic tears. I think your book doesn't talk much about them. I think maybe we've already hit the part of the book that does talk about them, but we have this diagram here, not diagram, the illustration here. You can see the aortic arch coming out from behind the heart and looping around to become the descending aorta right here. There is an inherent weak place if you have major shearing forces. And when do we see major shearing forces? Thinking back to trauma overview, with a rollover collision, a high-speed T-bone collision, or a rapid rotational type mechanism of injury. Your book mentioned that there's a high instance of aortic tears. Right here where they don't do a good job of where the subclavian artery comes off of the aortic arch, right in that area, according to this illustration anyway. That tends to be where those tears are. You have the largest artery in the body looping around, and you have a considerably smaller artery coming off, and that smaller artery it can't withstand the forces that larger artery can. So that's how that works out. The neurovascular bundle. This will become important to you, more important to you in your advanced EMT portion of our curriculum, when you learn to do needle decompressions of the chest. When we do those, we stick a large bore angiocath IV catheter. That's the needle with the Teflon catheter over the top of it is an angiocath. Stick a large bore angiocath, and the way I was taught to do it, you stick so that you hit the top, the upper part of the rib, and then you walk that angiocath up over the top of the rib and then straight into the chest cavity so that you're perpendicular to the chest wall. We do that because if we go under the rib, the neurovascular bundle is there. So there is a, excuse me, there's a nerve, and then vascular, there's both artery and vein tucked up under the bottom edge or the inferior margin of each rib. And if we get into that, we can actually damage a nerve and paralyze a portion of the chest wall, or we can lacerate artery or a vein, and we can cause unnecessary complication. I think this should be, again, nobody ever asked me, but I think that if you can identify a tension pneumothorax, and I think EMTs can assess patients well enough to do that, I think lives would be saved by teaching EMTs to do pleural decompressions. But nobody has asked me, and the latest and greatest scope of practice model came out about a year ago, and it still does not have pleural decompressions for EMTs. We do have pleural decompression for advanced EMTs, so maybe someday they'll follow my advice, and I think it would save lives save lives, but nobody asks. So what's the purpose of the ribs? Protects the vital organs of the chest. It also provides structure to the chest so that when the intercostal muscles contract, and that allows the semi-rigid ribs to be pulled anteriorly and superiorly to work in conjunction with the diaphragm to do what? Create negative air pressure in the chest, so that creates a pressure gradient so that our patients can move air into their lungs, right? Mediastinum, I mentioned earlier. Mediastinum is, where was that better picture? Okay. The heart and the great vessels, which would be the aorta, and all you see here is the superior vena cava, and then the carotid arteries there. Those lie between the lungs, and that's what the mediastinum is. It's that area between the lungs where these structures lie. What else is there? The trachea and the esophagus. Heart, great vessels, esophagus, and trachea. I got it right. All right. I'm 1 for 1 today on getting things right. I didn't keep score up till now. I couldn't think of the term intercostal muscle earlier. I stammered around in a circle and said something else. But I already talked about thoracic aortic dissection or tear. Okay. What would we see sign and symptom wise with our patients if they hadn't already died, or at least if they weren't hemodynamically compromised to the point that they're just short of going into cardiac arrest on us? Patient might tell us that they had a horrible tearing pain in their chest right after they were T-boned by the vehicle going at a high rate of speed. We'll talk more about that stuff in just a minute. You know what the diaphragm does. Nothing new there as far as how the mechanics of ventilation work. I know you have that down pat at this point because your grades reflect that. Something that we may have mentioned before, I think that they bring it out a little more in this chapter. If you have a patient with a spinal injury with cord involvement below C5, they can still breathe from the diaphragm. So what does that tell me? That tells me that the diaphragm is innervated by a nerve that arises below the C5 level. What nerve causes the diaphragm to contract or flatten out? That, where'd it go? It just left me. Oh, good grief. The phrenic nerve. I'm sorry. Wow. The phrenic nerve comes off the spinal cord below that C5, C6 level. So a patient with that lower cervical spine fracture, they can still breathe from the diaphragm. Patients with a spinal injury with cord involvement above C3, they may completely lose the ability to breathe. And what's treatment for that? Positive pressure ventilation. Do all of those patients die? No, they spend their lives with if they don't have other injuries, that cause them to die, and if they receive positive pressure ventilation, or initially that they would need ventilatory support, probably from somebody on scene. So we're probably talking the dreaded mouth to mouth at that point until there's a BVM available. As they're treated, they go to rehab, they work through their injuries, they are required to spend their life with a portable mechanical ventilator to keep them alive. Some of you will remember Christopher Reeve, played Superman back through the 80s and early 90s in the 432 Superman movies. He was involved in a horse jumping accident and had a high spinal fracture and spent years and years on a portable ventilator, and was an advocate for people with spinal injuries, and I think brought a lot of attention to spinal injuries and the things necessary in someone's life for them to go on and lead their new life. Life won't be the same as it was before, but he found ways to go on. Remember minute volume or minute ventilation? That is in milliliters or liters, the total amount of air moved through the lungs in 1 minute. That's tidal volume times respiratory rate, normal tidal volume, about 500 or 600 milliliters, respiratory rate 12 to 20. So that gives you between 6 and 12 liters per minute as the normal minute volume or minute ventilation in an adult. What happens when tidal volume decreases? Has the oxygen demand of the body gone down? If we're talking trauma, probably the oxygen demand of the body has gone up. This patient may be compensating and fighting shock, so that oxygen demand may have increased, and if tidal volume has decreased, the option that the body has to compensate for that is an increased respiratory rate. So what does that increased respiratory rate tell us when we assess our trauma patients? That tells us that there is either a much higher oxygen demand or something is impairing tidal volume, such as maybe blunt force trauma to the chest, and there's a giant boxing glove sized bruise or contusion to the intercostal muscles, and maybe a couple of fractured ribs in there. Why would that hurt tidal volume? Even if it's just bruised ribs, it hurts to take a full deep breath. So patients take more shallow breaths, but their respiratory rate increases. So when we find increased respiratory rate, part of our patient assessment needs to be that we locate, if possible, the cause of decreased tidal volume. And what do we do about that? We can use positive pressure ventilation to bag assist our patient so that we can artificially maintain appropriate tidal volume and respiratory rate, even though our patient between our breaths has shallow, inefficient respiration or respiratory rate. We can we can compensate for that with by utilizing a bag valve mask for positive pressure ventilations. What are the risks of that? These tend to be calls that get our adrenaline going, which gets our heart rate up and gets us in fight or flight mode. And we tend to want to squeeze that bag completely empty. Well, that adult bag is, depending on the bag, 1,000 to 1,500 milliliters, way too much tidal volume. But do we have something that maybe has less tidal volume? Yes, that child bag is about 500 to 750 milliliters. And you'll see flight crews do this all the time. They'll grab, in an adult, maybe even my size, they will grab that child bag and they will use that so that they don't overinflate the lungs. Things that happen, we cause gastric distension, which if you fill the stomach up with air because you're too aggressive with your ventilations, that interferes with the diaphragm flattening completely out. So we've compromised our patient further, and if we continue to distend that, the stomach can hold, in an adult, average adult, can hold about 4 liters of volume, roughly. It doesn't take long to get 300 or 3,000, 4,000 milliliters of air in the stomach. And then we've filled that stomach up, and that gastric distension interferes with ventilation, which interferes with oxygenation because we're not moving sufficient air down into the alveoli to be oxygenated. So that can cause some severe problems. When we talked about gastric distension in CPR about seven weeks ago, probably it didn't make as much sense as hopefully this does now. And then we also have impaired lung function. It's called barotrauma. We can start to rupture the smaller alveoli by pushing too much pressure down there. And then what happens? We've ruptured alveoli. We have fewer and fewer alveoli to be involved in ventilation, so oxygenation of our patient is impaired. So that can be a really bad problem. Increased intrathoracic pressure. What can that cause? We can reduce cardiac output because that pressure in the chest prevents complete refill of the ventricles. So when they contract, you have decreased stroke volume, so that we have fewer milliliters of oxygenated blood being squeezed out of that heart during systole, and that impairs perfusion systemically. But the first place you're going to see it probably is in your patient's mental status. Their level of consciousness will worsen. So we can cause considerable problems by getting too aggressive with that BVM. You're saying, well, gee, I just won't use that sucker. Now you cause equally bad problems by withholding ventilation. We just have to be good clinicians and provide the proper tidal volume, 500 to 600 mils approximately. If we provide the proper tidal volume, then we're going to do all right. Another thing on tidal volume, if our patient, if we're supplementing a breath when they inhale and we just give them a little boost to get appropriate tidal volume, that can't be as much tidal volume as you would have if you were strictly bagging the patient and providing the complete breath. So how much do we ventilate? We don't have to guess when the patient's taking a breath or when they're not taking a breath spontaneously. If we watch for chest rise, just like we learned 7 weeks ago, if we watch for chest rise and we stop squeezing that bag when we see good chest rise, we don't have to guess. What does that mean? We're going to provide more tidal volume at some times than we do others. But that's just being a good clinician. Do I know how much that is? No, I don't know which patient we have yet. Do you know? No, you don't know which patient we have yet. And I guarantee I've been at this for a long time, but I always have to fight the urge to squeeze that stinking bag too hard, because it turns out the old guy who thinks he has tons of experience has adrenaline also, and I go into fight or flight mode. 2 types of chest injuries, those that are open and those that ain't, right? Open chest injuries, closed chest injuries. Closed chest injury, the skin isn't broken. We don't have anything that we visualize that could have penetrated into that chest cavity. What caused this abrasion and ecchymosis across this patient's chest? Anybody want to guess? I'm betting that that's a pretty significant little seatbelt contusion. So what did that do? Maybe there's some blunt force trauma because of deceleration forces. Also kept that patient in the vehicle and kept that patient from flying around all over the vehicle. So those are a good thing to see. Are they painful for the patient? Yes. And your patient is going to have pain on inspiration, probably, and that may decrease tidal volume. So we need to be prepared to treat that if it's symptomatic in our patients. Closed chest injury, depending on the significance of the mechanism of injury, could cause contusion or bruising to the myocardium, so cardiac contusion or myocardial contusion, or pulmonary contusion. That would be a contusion to the lung itself. That contusion to the lung, to the parenchyma, or the body of the lung, that's going to damage alveoli. That's going to interfere with oxygenation. And how much? It depends on how big the contusion is, right? It also depends on what other structures in the chest may be injured or damaged. It takes significant closed blunt force trauma to the chest to cause a pulmonary contusion. So you also have a high risk of a myocardial contusion, maybe some tears in there that are bleeding. A patient could develop a pneumothorax, things that we need to stay on top of, and we'll talk about the assessment of those here in a minute. Damaged heart, or the heart that has suffered that myocardial contusion, that bruise may interfere with, because bruising causes swelling, right? If that swelling is significant enough, it may decrease the amount of blood that can move into the heart during diastole, which is going to decrease stroke volume, which is going to decrease cardiac output, which will decrease perfusion, and it will manifest itself in our patients. Rib fractures can cause significant damage to tissue, and that can lead to hypovolemic shock. What do we lose when we bruise lung tissue? We have a loss of surface area involved in ventilation and oxygenation. So that's what causes the problem there. Apparently this is an open chest injury. Something has penetrated the chest wall. Here it appears to be a rib. It could be a knife, a bullet, it could be a chunk of metal. It could be a gear shift in a vehicle that didn't have a gear shift knob. It could be a sharp branch, a broken branch in a tree. Somebody's trimming a tree and they fall and their chest is impaled on like killing a vampire, right? There's a stake made of wood that's penetrated the chest. We don't see very many vampires in trees, and of the ones we see, they seem not to be very industrious, so they don't trim a lot of trees. They don't tend to fall, since apparently vampires can fly. So don't worry too much about the response to an impaled object in a vampire. Don't be pulling those stakes out. They'll come back around and you'll have more trouble than you started with. Okay, rebar. I've seen rebar stuck through somebody's chest. Ribs are really common. Don't remove that object. Don't move it. Stabilize it in place. When might we move it or remove it? If our patient needs chest compressions and the placement of that impaled object is such that we can't do chest compressions, then you remove it. Document that extremely well. Document where, draw a diagram. Well, that was easier in the old days when we did patient care reports. Now it's all electronic. You're going to have to type that out and describe where that impaled object is and why that interferes with your ability to do chest compressions. You'll put that in your narrative that you type and make it really clear, that paint a great word picture of why you had to pull that out. Probably CPR won't help anymore if you've had to pull an impaled object out of the area around your patient's sternum. But strange things happen. It's amazing the things that people are able to survive. Just depends on the trajectory of that impaled object. So what does blunt trauma cause? That mechanism of injury is responsible for fractures to the ribs, occasionally the sternum. It takes a high energy mechanism of injury to fracture a sternum. Those things are, when you find a fractured sternum, that carries with it a high degree of responder pucker factor, and we need to scoot and get that patient some help. Rapid transport is what I'm talking about. Treat that with skinny pedal on the right therapy or appropriate application of diesel fuel or gasoline, depending on your vehicle. That causes bruising to the lungs, the heart, could cause damage to the aorta, can actually tear, and these patients are going to be obviously dead, but it is possible for the aorta to be sheared completely away from the heart. It's possible for the lungs to be torn completely away from their attachments in the chest, those patients don't do well. Those patients are likely dead on the scene. Or if you're in a BLS only ambulance and you initiate resuscitation because you're not sure what's going on inside that patient's chest, obviously, and you don't have the benefit of a cardiac monitor showing asystole, you may attempt resuscitation and they may call the code as soon as you get to the hospital, or pronounce the patient dead is what I mean by call the code. Okay. Signs and symptoms of injury to the chest: pain at the site of the injury, localized pain. I can take one finger and I can point to the area where the pain is the greatest, where it maybe even appears to originate from, and the pain is worsened by breathing. So what do I want to do? I don't want to breathe as deeply. So what are you going to do? You're going to assist my ventilations with a bag valve mask, and it's going to hurt, and you're going to have to explain to me that you're trying to help me and it's absolutely necessary, and explain what you're doing. We may see bruising to the chest wall. We may palpate crepitus as we palpate and follow the ribs around in our rapid trauma, and then in our secondary head-to-toe trauma assessment. We may even find some subcutaneous emphysema when we palpate the chest. That comes from free air in the chest that's making its way to the subcutaneous area, and you get that Rice Krispies feel when you palpate the chest. And of course, dyspnea. It hurts to breathe. So I'm breathing fast, or there's damage inside my chest, and maybe I'm going into hypovolemic shock, and I'm fighting to breathe. I'm breathing rapidly. How do we treat all of that? We treat that if the dyspnea is combined with chest trauma, then we're going to treat that with positive pressure ventilation. Get on that. Just watch your rate and your tidal volume. Don't get overexcited. You're going to be a big help to your patient. Initially, with patients with chest trauma, don't wait till you get your SpO2 monitor on your patient and you say, oh, well, they're 95% now. That's not 94 or below. Or it's 94. Maybe I'll just put a nasal cannula on. No, these patients with chest trauma need a non-rebreather mask, 15 liters per minute. That's if they have appropriate tidal volume and appropriate ventilatory rate. If either one of those is off, they're outside normal limits, then let's get somebody going with a bag valve mask with reservoir bag connected to 100% O2. Anytime I say bag valve mask, know that the reservoir bag and connected to 15 liters per minute or more of oxygen flow rate, so that we provide almost 100% O2 to our patients. Hemoptysis. If your patient has a hemothorax, they may be coughing up blood. Hemoptysis, generally that's going to be a more frothy kind of blood because it has air from the chest in it as they cough it up. If it's dark red blood, you may have a different problem. when your patient has a much bigger problem than you do, because you get to go run a different call after that one's over. Your patient's fighting for their life. If we visualize chest rise and fall in our patients, and we see that one side isn't expanding normally, that should be a big time red flag that our patient may have a significant pneumothorax. And then does our patient have signs and symptoms of hypovolemic shock? That's going to go with a hemothorax or tension pneumothorax. And other signs of tension pneumothorax and hemothorax or hemopneumothorax, which is possible. You see a decent number of those. Cyanosis around the lips and fingernails. We need to immediately get on assisted ventilations with BVM is definitely indicated when we see our patients with cyanotic fingernails and circumoral cyanosis that goes around the lips and includes the lips. It's not just around. Rapid shallow respirations, which we already talked about. Pain from the injury just causes them not to take a deep breath. They're not moving enough air. How do we know that? One tool is in our bag of tricks. One part of our assessment, we'll see decreased chest rise from what we would normally expect in a patient of that age and size. We're also going to auscultate patient's chest in multiple locations and be sure to auscultate lots of chests with appropriate normal tidal volume so that you know when you hear decreased breath sounds. There's no doubt in your mind. If it's borderline, you may not hear it. We're listening for the big time cases here. All right. Let's move on through scene safety. We're just following that patient assessment algorithm that we gave you at the beginning of the semester. Comes in really handy so that you perform a systematic, thorough assessment of every patient that you encounter. Number one, that scene has to be safe for you to enter, for your partner to enter. Once we're there, we could have what appeared to be a stable scene going in. Maybe we're just dispatched to chest pain in the middle of the afternoon, and we get there and start to assess our patient, start to get a sample history, and we determine that our patient has, well, we're going to see this before the sample history, they have a knife sticking out of their chest. Yes, they have chest pain, but whoever called 911 just said they had chest pain. Yep, anytime you have a knife or an ice pick sticking out of your chest, you're probably going to have pain. So what do we do at that point? We need to withdraw from that scene, call PD. What you will see more commonly would be just a swoop and scoop with a patient, scoop them up, get them in the back of the truck. But textbook answer is to withdraw, contact PD, wait till the scene is secure to go in. But if you're on scene and you determine that your patient has a knife sticking out of their chest, you're going to see a lot of EMTs and medics just grab them, throw them on the cot and go. And then last in scene safety is bystanders. That's more of a law enforcement function. That doesn't mean that we don't say get back, get out of the road, do whatever but that can't be your primary focus, or you're distracted from your patient and you're not meeting the standard of care. You're not providing reasonable care to your patient. Try not to disturb the evidence at a crime scene. Most of the time we can do that. Occasionally there's just no way around slight disturbance of the crime scene. All calls involving violence, we need to contact law enforcement. Use your PPE, that goes without saying. Mechanisms of injury. Let's stretch our legs for 5 minutes and then pick up with that. Mechanisms of injury. We've been talking about them since we started this chapter. When do we suspect chest injuries? We should always be looking for chest injuries. Why do I say that? Because we're going to do a rapid trauma assessment and then a full head-to-toe physical exam of our patients, of our trauma patients, and we're going to be looking for chest trauma. When I say chest trauma, I'm not just talking about the anterior chest or the ventral surface of the chest. I'm also talking the posterior chest or the dorsal aspect of the chest. When do we see that? We get one shot when we log roll that patient onto a backboard. If we're going to provide full spinal immobilization of our patient, we get one shot at assessing that back. So we need to find everything then. That may be before we get down to doing our full head-to-toe physical exam. In fact, if you have a critical patient, you may not get much past your primary survey of your patient throughout your transport, because you're finding and fixing life threats, not moving on until they are fixed. So you may be stuck. So DCAT BTLS assessment of the back quite often is going to come in that rapid trauma when you log roll that patient to get them on the backboard and C-collar and cervical immobilization device. So those of you who are very orderly, sequential people, that may bother you a little bit. I'm going to tell you, this is EMS. You're going to have to roll with you're going to have to go with the flow every now and then. And the flow here is, we've got to visualize, have to inspect, auscultate, and palpate. We may not get much into auscultation of the posterior chest in trauma, but why did I say inspect, auscultate, palpate? That is the order of examination of our patients. So we're going to inspect, we're going to do a good inspection, and we're going to palpate for a couple of things. These different trauma, these various body systems don't exist in a vacuum. So besides palpating for fractures of ribs and that posterior chest wall, we can also palpate down the spinous process all along there and palpate for step-offs, even though the log roll you may not be able to palpate that as easily. If your patient is in a lot of pain, they may guard or stiffen up, that may contract muscles when you log roll them, and it may make it harder to palpate some of those spinous processes. That doesn't mean you don't try, right? Determine the number of patients. That's always important. You could have multiple patients with chest trauma. Maybe they had just a good old West style shootout, and you have 2 patients with bullet holes in their chests. you don't always see them squared off in the street shooting at each other, but it's, this isn't Buddy's war story time, but I was one of the responders who responded to a gunfight at a wedding reception at the fairgrounds. And boy, Nicole's father-in-law might remember the exact number of patients or have a better recollection than me, but I remember transporting about 12 people with gunshot wounds from that little thing. Apparently the two sides of the family didn't get along too well, and everybody decided it'd be a good idea to bring a gun. And something after sufficient quantities of liquor flowed at the reception, so did the bullets, and it was quite a Saturday night. That's one of my memories of a mass casualty incident. I don't remember having anybody dead on the scene, so at least they did that well. I mean, they turned over tables, took cover behind tables, and were exchanging gunfire across a reception hall. Quite a deal. Right here in Amarillo, Texas. Who would have thought? Okay, just like always, general impression. Is this patient critical? Is this patient not critical? Address life-threatening hemorrhage immediately. Trouble with a lot of this life-threatening hemorrhage with these chest injuries is that they're on the inside. You can't hold direct pressure on a lacerated pulmonary vein or a pulmonary artery. You can't put a tourniquet around a lung. This internal bleeding, again, this is a surgical condition. Skinny pedal on the right therapy. What takes all four limbs to fly a helicopter? Maybe that's indicated. Experience will, I would, something to remember, I think, is while you're gaining experience, so you have a better feel for what is life-threatening, err on the side of caution. If you think your patient's in deep weeds, it's better for them, and I've been there. That's why I'm saying this. It's better to have an ER doctor say, "Why the hell did you run that patient in hot?" Or "Why'd you call a trauma alert when it's only blah blah blah?" Well, that he has the benefit of being a physician with enough experience to be an ER doc, and they just do that stuff sometimes. It's okay. Err on the side of caution. Be your patient's advocate. Get them there. If everybody in the ER laughs at you and they give you some creative nickname because you ran a patient in hot when there was no big deal with that patient, at least you were doing the best that you could for your patient. With experience, you get a better feel for which patients are circling the drain and which ones maybe don't have life-threatening injuries. That's all right. Remember that the first time, so maybe it doesn't happen to you, but if somebody laughs at you or they kid you, that's just part of medicine. We just kid the heck out of each other and give each other creative nicknames, and that's okay. Just take good care of your patients. Rapid physical exam. Every trauma patient is going to get that, right? Yes, everybody nodded their heads up and down, even though I couldn't see you. We're gonna find obvious injuries, right? We're gonna be looking for blood. We're gonna be looking for dyspnea or irregular breathing. Do we see cyanosis? We just move right on through that rapid trauma. Do we have equal rise and fall of the chest? Very important when we're talking chest trauma and pneumothorax, hemothorax. Accessory muscle use, what does that mean? They're fighting to try, so they're engaging neck muscles. they're engaging abdominal muscles. Why are they doing that? They're fighting. Why do they fight so hard? Why don't they just chill out, and maybe it wouldn't be quite as hard on them. They wouldn't be using up as much oxygen. They don't even know they're doing this. Accessory muscle use is a compensatory mechanism that the body engages to try to open that thoracic space up larger. Why? To create more of a pressure gradient. So we decrease interthoracic pressure more if we're able to expand that chest cavity more. So that's the whole purpose of accessory muscle use. I'll show you a picture in a little bit of some grossly distended jugular veins. And with the trauma that we're talking today, we're not talking about, you notice when the guy sings and he holds a note for an extended period of time, you see his jugular veins pop up on his neck. And after you're a paramedic, you think, yeah, I could get a 14 gauge in one of those external jugulars. No problem. I still do that. We're talking, I mean, the size of a cigar or bigger. I'll show you a picture in a minute. And then good ABC assessment. Do they look sick? Are they going to die or are they not going to die based on their appearance right now? Okay, let's assess some airway and breathing. Do they have an open, patent airway? So we're just working through the same stuff we've done all semester. Get on that spinal immobilization early. Err on the side of caution with that one in your patients with significant mechanism of injury. Let's see if we can see some distended jugular veins. We're going to hope. Oh, maybe something's happening. Oh, no. They took it down. Okay, I'll find a picture for you at some point. Man, that big buildup I've been telling you all about, they're the size of a cigar and yada, yada, yada. And no, dadgummit. All right. Distended jugular veins. So think the size of your patient's thumb or bigger. That's what I'm talking about. That's a big jugular vein sticking off the side of somebody's neck, right? It's a sign of increased pressure or tamponade of the heart. So why would that cause distended jugular veins? If there's increased pressure around the heart, that impairs refill. And when you impair refill of the right ventricle doesn't move as much blood during systole to move that blood out through the pulmonary arteries and out into the lungs. So it's just like having a partially plugged drain. That's going to cause, or partially plugged sewer line. That's eventually going to cause things to back up when the water backs up into the bathtub and the sinks. It's a horrible thing. If you have a floor drain, it starts flooding your garage. Just think of those grossly distended jugular veins as having a partially plugged sewer line. It's causing blood to back up into the jugular veins. It can also impair cerebral blood flow because if enough blood backs up the jugular veins, external and internal, drain deoxygenated blood from the brain so that oxygenated blood can circulate. So why would mental status be altered with that patient with chest trauma that's causing those grossly distended neck veins? the brain isn't being perfused as well, because for a couple of reasons. You have that increased pressure that eventually clogs up the drain, clogs up the blood flow, or impairs the blood flow. But if we have poor refill in the right ventricle, we're going to have poor refill in the left ventricle. And what's that going to do? It's going to decrease stroke volume, which impairs cardiac output, which is going to impair perfusion. And the first big place you're going to see that is altered mental status in your patient. At the same time, you may note that your patient has sluggish pupils, sluggish pupillary response because of hypoxia. So all of this works together. None of it exists separately. We assess it separately and sequentially in a way, but part of your critical thinking, part of the analytic mind of a clinician, you have to consider how all this works together and what the impact of this trauma is systemically in your patient. Breathing present, is it adequate? If there's a problem with either, what are we going to do? Somebody get the BVM out and bag assist. I'm the one assessing the patient. I'm the team lead. Maybe we're on a BLS only unit and I'm the team lead. And so after I tell somebody to start bagging that patient, what's one of my responsibilities? To keep an eye on them bagging that patient. That's a little bit too much tidal volume. Just back up on don't squeeze the bag so hard. That rate's way too fast. Take a deep breath with me and slow that down. I just want 10 breaths a minute. Let's just assist 10 breaths a minute. Make sure you just get good chest rise. So you're responsible for all of that. So as you move on through assessing your patient and you're directing, okay, go ahead and let's throw a gloved hand over that penetrating chest wound there and get an occlusive dressing on that for me. And you need to point to people and you need to give them jobs, and then you need to make sure they're following through on the job that you gave them as you move through assessing your patient. So you're responsible for a lot, and I guarantee you every one of you can handle it. After you have more experience, you will feel much more comfortable doing that. But that's not the time to say mother may I and please. That's you don't have to be a jasonky about it, but be assertive and give people, assign roles, give people jobs to do. And if it may be that you know everybody on the crew, and Jim, get an occlusive dressing on that penetrating wound on the left side of the chest there for me. Bob, let's slow down on those ventilations a little bit. Not quite as much tidal volume. There you go. That's good. That rate's better. Yeah, that's, what do we call that when we assign a role, they repeat back to us, they've accepted that role, and then we keep an eye on what they're doing. It's called closed loop communications. So if we assign a role, we need to make sure that somebody accepts that assignment. It's when I teach CPR, and starting when I teach Cub Scouts and Brownie Scouts CPR, I tell them every time to point someone and tell them to go call 911, get some help coming, come back and tell me what 911 said. Well, I know what they're going to say. Why do I say that? It's closed loop communication. I want them to get it in their mind that they need to assign that job and then have somebody report back to them so they know that job's been complete. You'd be amazed at how often somebody called 911 and 911 is never called, even though we all have this magic communication device on our belts. Everybody will think somebody else called 911. So don't assume that a member of your team heard what you asked them to do and then started doing it. So work on that closed loop communication, assign that task, have them tell you that this. So you say, Bob, go ahead and grab the BVM and start bag assisting him 10 breaths a minute. And if Bob doesn't say anything, hey, Bob, did you hear me? I need you to go ahead and start bagging this patient. Bag assist, just get good chest rise, 10 breaths a minute. Okay, I got it. That's what I'm talking. Those are the things that you need to practice so that they work for you in a stressful situation. Look for full expansion of the chest wall. Do we have unequal chest rise and fall, or do we see something like this bad boy right here? Ouch. That's chest. What do we call this piece here? That, okay, now I got to get out of there. Go away. We don't need to do EKGs yet. We'll save that for tomorrow. No, we won't. That's all right. That's paradoxical motion. What is that telling me? That is a flail segment. That means that my patient has 2 or more sequential ribs fractured in 2 or more places, so that when they inhale, that flail segment, that floating little piece of chest wall, pushes down against the lung when the rest of the chest wall moves out, and then when the rest of the chest wall moves in, that flail segment goes out. So that's paradoxical motion. That goes with a flail chest. What is that doing? Every time that pushes in, it squishes down on the lung, right? To use precise clinical terms. So it compromises, oh, dang it. That compromises tidal volume, right? So that decreases the amount that the lung can inflate. So that impairs ventilations, which is going to impair oxygenation. So how do we treat that? We're going to support ventilations. If we see a patient with the flail segment, immediately we need to get somebody going with positive pressure ventilations. That is our treatment for this. And we'll talk about it again here in a few minutes. We're going to see it twice. Why? Because I think it's important. So I added an extra time in there. Reassess. How often we're going to reassess? We've done this all semester. Oh yeah, reassess critical patient every 5 minutes. When we're managing airway and breathing, we need to have constant assessment of the management of our patient's airway and breathing. Well, then I can't do anything else. Well, yeah, yes and no. You assign somebody the role of managing that airway, providing positive pressure ventilations, and if they're inexperienced, just tell them, and I would tell them anyway, you don't assume anybody's expertise or experience. Just tell them to let me know how bad compliance is if it changes. What is that? Normal bag compliance, it should be easy to squeeze that bag on that bag valve mask and ventilate that patient. Poor bag compliance means it starts to get harder to squeeze to the point that maybe you can't even squeeze that thing. So you assign that role of providing positive pressure ventilations, and you say, hey, Bob, let me know if that bag compliance changes, and don't wait for me to reassess to do that. You see, but if you feel bag compliance changing, let me know right away. All right. All right. That's closed loop communication. Bob is going to be thinking about bag compliance. Bob's going to be thinking about the rate and depth of respirations. And if it changes, Bob should tell us. As we reassess our patient, we also, part of that, as we're getting vital signs, then go ahead and ask Bob, how's that bag compliance doing? Oh yeah, it's still good. Or yeah, it's kind of getting worse. So maybe that means Bob didn't pay attention for 5 minutes, but don't think the worst of the people on your team. And then be alert for decreasing oxygen saturation. First place you're going to see poor oxygen saturation show up is going to be with decreased mental status, but also let's say that patient's unconscious, unresponsive. To start with, we're going to be watching the SpO2 monitor to see how well our patient's O2 sat is doing, but we can also keep an eye on their color. And when we assess those pupils every 5 minutes, when we reassess our patient, those pupils responded pretty briskly 5 minutes ago. Now they're really sluggish. What do we need to do? We need to do something about the rate and depth of respirations and the FiO2, how much oxygen we're delivering per breath. If we're doing all we can, all of those places, then there may not be anything we can do. Our patient is decompensating. Our patient is crashing on us. And what can we do? Get them to a surgeon faster, maybe have ALS rendezvous with us on the way in, or get a helicopter to us. Narrowing pulse pressure. If we have a patient who's developing a tension pneumothorax, what is that? A pneumothorax is air accumulating in the chest cavity so that it starts to occupy part of that hemithorax, and that decreases the volume of air that can enter that lung during ventilation. As that progresses, bag compliance changes. It gets worse. Okay, we just talked about that. Narrowing pulse pressure. We've already talked about this. The ventricles can't refill completely, so the systolic pressure is going to go down. What is pulse pressure? Thinking way back there to 6 weeks ago, pulse pressure is systolic blood pressure minus diastolic blood pressure. That gives you the pulse pressure. That's the difference between the two. So if we're trending vital signs and we start to see that systolic pressure coming down and starting to approach that diastolic to the point that pulse pressure is getting lower and lower, that is a sign of a tension pneumothorax. And then we start to see jugular venous distension. And as we auscultate breath sounds, we note that the breath sounds are diminishing steadily on one side. Eventually it can cause decreased breath sounds on the other side. That's the tension part. As it starts to involve both sides of the chest, instead of a hemithorax being involved, we start to see some involvement over into the other side of the chest. And as this tension pneumothorax develops, let's go through the rest of these now. We have a picture to look at. Pulse rate and quality. Heart rate goes up, and quality, the the pulse starts to feel more thready. You don't have a strong bounding pulse anymore. It starts to be more thready. You don't feel as strong of a pulse. Skin color and temperature, your patient starts to get pale and cool. This is a right now emergency. Manage any life-threatening external bleeding, and we need to, if there's penetrating chest wound, we need to put an occlusive dressing over that. We need to call for ALS, and we don't need to wait around on the scene for them. We need to be gone in less than that, way less than that platinum 10. We need to be on the road. ALS can meet us on the way, or we can make arrangements for the helicopter to meet us on the way and establish a loading zone, landing zone, and LZ on the way. But these patients need a surgeon like right now. They need ALS so that we can decompress the chest and hopefully reverse some of this some of these advancing signs and symptoms. And we stick them again and again, trying to get that air out of the chest. And you pop that thing through, you hear air go. That's if you're in the right place and it's doing any good. Okay. Priority transport, patients with problems with ABCs, the obvious problems with ABCs, rapid transport. Subtle clues, changes in the appearance of the skin, decreasing level of consciousness. If the patient tells you, I feel like I'm going to die, don't let me die, they're not joking with you. They're not playing around. That sense of impending doom, believe that when your patient tells you that. That is noteworthy. We need to beat feet to the hospital. We don't hang around on the scene and do a full secondary head-to-toe DCAT BTLS survey. Our patient's gotten a rapid trauma assessment. We've gotten a good baseline set of vitals, and we're managing life threats, and we're off the scene, and we're scooting toward a surgeon. Err on the side of caution. Transport rapidly to the appropriate hospital according to your protocols. Deadly dozen chest injuries, things that will dadgum sure kill you. Airway obstruction, bronchial disruption, could have just torn part of the bronchial tree away from the lung. It's a major thing. Diaphragmatic tear, that takes considerable trauma to cause that diaphragmatic tear. Esophageal injury, again, significant trauma to tear that tough muscle. Open pneumothorax, tension pneumothorax, hemothorax, flail chest, cardiac tamponade, aortic dissection, and myocardial contusion, pulmonary contusion. Yes, those are, I agree with the deadly dozen. Those are in this book, but those are also, I've looked at some old surgical textbooks from, way back from the 40s and 50s. Some terminology may have changed over that time, but you pretty much see that deadly dozen way back then too. Investigate the mechanism of injury. As you investigate the chief complaint and you determine what the mechanism of injury is, that's going to give rise to your index of suspicion as to what's wrong with your patient. And then as we work through that rapid trauma, and then maybe we're able to get down to sample history and OPQRST, then we start to identify signs and symptoms. And pertinent negatives, what in the heck are those? Why are those important? If your patient has their unrestrained driver in a high-speed rear-end collision, now let's make it they ran into a stationary object. So there is a concrete wall, and it is a reinforced concrete wall holding back tons and tons and tons of good, rich soil. And your patient has a fogged up windshield or icy windshield, and they manage to scrape out a little hole right in the middle, and they're using that to drive, and that gets a little foggy and they can't see, and they're going 50 miles an hour, and they run straight into that reinforced concrete wall. They're unrestrained. They have a steering wheel bruise on their chest, and they deny any shortness of breath. They and so that would, and they deny any chest pain. Maybe think about their mental status if they're denying all these things, but those are pertinent negatives that you would report to the hospital. You would report that patient has a large steering wheel bruise to the anterior chest, and patient denies any pain to the chest and denies shortness of breath. That's important. Sample history, we may not ever get there. We may not get a sample history. There may be nobody who can give us a sample history. Do the best you can, but don't hang around on scene, and don't miss life threats because you're trying to make sure you find out if they're allergic to penicillin or when their last oral intake was. Get that when you can, but don't let that slow you down. Focusing on the mechanism of injury. What was the speed of the vehicle? What was the height of the fall? When they fell, did they land on their chest? Did they land on the crown of their skull? Did they land on their heels? Did they fall and land on their lateral chest? What did they land on? Did they land on metal bars that were sticking up, or did they land on a bed of feathers? I've yet to have a trauma patient who landed on a bed of feathers, but you never know. I'm not that old yet. I could still see one. Use of safety equipment. Was the patient restrained with the seatbelt? Were airbags deployed? Were all of those things? Type of weapon used. Was it a knife, or were they shot with an AR-15? Number of penetrating wounds, all are important. If you have an isolated injury, then we can focus more on that injury. Again, don't delay transport. We're still inspecting and palpating the anterior and posterior aspects of the chest wall. That's good. Any changes in respirations over the time that you've been treating this patient. And then we're down to DCAT BTLS head to toe. Vital signs, same ones we always get. We're going to reassess those every 5 minutes, maybe less if we have time. Might set that automatic blood pressure cuff to get a pressure for you every 3 minutes. That would give you a better trend of blood pressure. But wait, buddy, you told us that falling blood pressure was that comes with decompensation. That's late in the game with hemorrhagic shock. Absolutely, you get a gold star for today because you all said that at the same time. I heard you all the way over here. So but that should also record a heart rate, which is that is a better indicator, right? If that heart rate's going up, they're getting more and more tachycardic. They're increasing the rate to try to compensate for that lack of red sticky stuff that's in circulation. So trying to maintain perfusion, trying to maintain cardiac output by increasing heart rate, right? Okay. Rapid respiratory rate, they're trying to increase oxygenation to deal with hypoxemia that's developing from losing the red sticky stuff, right? Work of breathing, is that changing? Do we start to see them engage accessory muscles when they weren't before? And pulse and respiratory changes, that may be later in the game with chest trauma. Reassessment, we're going to repeat the primary. We're going to reassess the chief complaint that now we've narrowed it down. We've already done a focused assessment of that isolated injury. And when we reassess, we're going to reassess the pertinent areas involved with that chief complaint. And we're going to assess our interventions, reassess our interventions, trend those vital signs, just like always. Make sure you have appropriate spinal immobilization in place and that's staying in place. And keep their airway open. Always have suction ready to go. If you have a patient with chest trauma, if you have a bad trauma patient, I'm going to say that, let's go ahead and have that tonsil tip suction ready to go right there beside the head, so that our person managing airway, all they have to do is grab that suction and suction that big blood clot out of the mouth, or suction. Our patient starts to vomit and start suctioning, and then get that backboard tilted up and propped up so that we decrease the risk of our patient aspirating that vomit or blood or whatever's in their mouth. And then consider an OPA, NPA if appropriate. Control bleeding, occlusive dressing. Any penetrating chest trauma, let's go ahead and put an occlusive dressing on that. I think I've told you before, you take that Vaseline gauze and you tear the package open, you throw the Vaseline gauze away, you put the sterile side of that foil packet over the wound, and you tape it on 3 sides. That is how we manage, that's how we apply an occlusive dressing. Trying to tape that stinking Vaseline impregnated gauze, that tape doesn't stick well to that Vaseline, and the best way is to tape the foil. Tape it on 3 sides so that with a tension pneumothorax or a simple pneumothorax, either one, as you ventilate the patient, as that intrathoracic pressure goes up, hopefully if there's free air in the chest, that occlusive dressing taped on 3 sides will allow air to go out of the hole in the chest but not come back in. And I think your book, so that's how I do it, and that's how I would recommend do it, because you're constantly dealing with air accumulating in the chest. I think your book still says to tape it on 4 sides, and then it talks about if protocol allows, then you burp it. You untape one end, open it up, and then that lets air out of the chest. I say, why wait for it to accumulate and impair the tidal volume of your patient? Just that's all right. So that's a difference in how I do it versus what your book says. I don't bring those out very often, or I try not to. I bring it out there because that can be a game changer for your patient as you go. What if my protocol doesn't have that listed in there? Well, then contact online medical control and ask for permission to tape the thing on 3 sides and provide positive pressure ventilations. I cannot even fathom that there would be somebody out there who would deny your request to do that for your patient. If you give a good report and you paint a good word picture of your patient's clinical condition, they're not going to tell you no on that one. Don't get hung up on distracting injuries, the non-life threatening. We're not going to spend time doing this nice, pretty sling and swath to manage that fractured humerus on one side, and we do the most pretty bandaging and splinting that the Boy Scout first aid book ever envisioned. Don't jack around with that. Just strap that arm inside the straps on the backboard or under your cot straps to try to stabilize it. You don't have time to mess around with bandaging and splinting with a critical patient. Don't spend time putting that traction splint on. Have somebody pull traction and then get the straps of the backboard down to hold that leg, or tape. You can take 3-inch tape and you can have somebody pull traction, and you can use tape to tape that leg down to the backboard to help provide some extra support to help stabilize that fractured femur the best you can. Don't mess with the traction splint. That's for isolated mid-shaft femur fracture in a stable patient, right? Right. Pneumothorax, the world calls that a collapsed lung. I call it a squish down lung. Why? Because there's air accumulating in the pleural cavity, in the pleural space, and it's as that air accumulates further over time, it starts to compress the lung. And if we can get, if our patient becomes hemodynamically unstable because of that, if they have penetrating chest injury, I've just told you how we can help deal with that. We need to call ALS because somebody needs to be popping holes in this patient's chest. And until such time as the world starts to agree with me and allow EMTs to do pleural decompressions, then all we can do is manage it the best we can until we can contact ALS and have them meet us along the way or respond to our scene depending on their response time. Diminished breath sounds. You're going to see that when the lung is compressed down 30 to 40%. Absent breath sounds, we're thinking tension pneumothorax right away, and then sucking sound on inhalation. Sucking chest wound, you thought they all sucked, right? Sucking chest wound, as your patient exhales, you hear the sound of air rushing into that patient's chest. As the lung deflates, then air goes through the chest wall into the chest. What do you do as soon as you hear that? We're using PPE, right? So you throw a gloved hand over that, you hold it there, and you have somebody get you something to apply an occlusive dressing with. Or you have somebody else throw a gloved hand over that so you can continue with your rapid trauma assessment. But somebody needs to get a gloved hand over that until we can get that occlusive dressing over there in the same manner that I just described. So, pneumothorax, we have air accumulating here in the chest cavity, and that's compressing that lung. It becomes tension when it starts to cause a problem in the mediastinum and then moving over to the other lung. Flutter valve or one-way valve, that's that three-sided tape job on that occlusive dressing that I just described. That makes a flutter valve. Let's see if this will. Looks like this one. Well, maybe. We're gonna see it. Hopefully we're gonna see an application of a chest seal. It's a commercial piece of equipment.
The first thing we need to do is remove the clothing to expose the injury.
Can you guys hear that?
When the injury is exposed, remove the chest seal from its packaging, and you can also examine the patient and check if there is an exit wound. When the chest seal is removed, clean the area of any blood or fluid. Remove the protective film from the chest seal. Place the chest seal directly over the hole. Ensure that the chest seal is in place. When the chest seal is in place, you may then inspect behind the patient, looking for any exit wounds of the bullet. Inspect your gloves where you cannot see.
Were you guys able to hear that?
Yeah, we could hear it.
Cool. Took me this long to, course is almost over and I figured out how to share the stinking computer sound. All right. Got to start somewhere, right? Okay. So he was talking about the exit wound. That's the other thing. In penetrating chest trauma, we need to look to see if there's an exit wound, and if so, we have two areas to cover. Those chest seals, I think that thing he just put on that guy's chest, those cost about $100, and you're not going to find that many ambulances with those when all you have to do is take Vaseline gauze, throw the gauze away, and tape the package over the chest. So some places have them, some don't. If you're on an ALS truck and there are some smaller holes to the chest, you could always grab an EKG electrode and throw that over that. That would be the type of occlusive dressing. But what can't you do with that you could do with your Vaseline gauze package? You can't, that EKG electrode, it seals and it doesn't make a flutter valve. But you could, if somebody had several penetrating wounds to the chest, you could open several EKG electrodes and throw over those and free up hands for assessment and treatment, and then you could get the flutter valve type of occlusive dressing secured to the patient's chest. Have to be creative, think ahead. I used to sit around the station. In fact, I'd go out and sit in the back of my truck, and I would look at all these cool toys that I had, EKG electrodes, and all kinds of fun stuff. How could I rig up constant irrigation using a nasal cannula with the things I have on my truck? How Look at that stuff and think of all the other ways you could use it besides its intended purpose. Doesn't make you wrong when you use that. Just because the manufacturer's narrow-minded and they didn't mention it doesn't mean you can't do it. It may involve contacting medical control and requesting permission. That's fine. Do that too. Document it well when you contact medical control and make a request and they approve it, and don't exceed your scope of practice. It is quite possible that you could make a life-saving difference in your patient by doing a pleural decompression as an EMT. You'd lose your job, you'd lose your EMT certification, you might not ever get your EMT certification back, but you might save a patient's life. We have to stay in our scope of practice and request help from people who have a higher scope of practice, or we use skinny pedal on the right therapy and get them to the hospital to somebody who has a higher scope of practice than we have. Okay, let's see. Simple pneumothorax, until that simple pneumothorax reaches 30 to 40%, we may not see a significant change in our patient. And a lot of these pneumothoraces that later on you go back to the ER and your patient has a chest tube and all this stuff going on, and you think, oh man, I screwed up because I didn't even hear decreased breath sounds. What did I say? It takes 30 to 40% compromise or collapse of a lung before you hear a decrease in breath sounds. So maybe it was at 10 when you delivered the patient, and 2 hours later it's at 60% and they're popping a chest tube in. That's all right. That's patients don't exist in a vacuum. They are dynamic creatures, and the effects of trauma on our patients are cumulative. They don't always experience the full force of, well, they experience the full force. All of the effects of the trauma aren't always experienced immediately with our patients. There are things that develop over time. Late findings with a simple pneumothorax: decreased breath sounds on the injured side. Lethargy, what is that? That's a decreasing mental status. Our patient's level of consciousness is going down so that they're kind of fuzzy and confused and they don't answer questions appropriately anymore. That's lethargy. And cyanosis, you know what that is. What is our pre-hospital treatment? High flow oxygen. We're going to monitor our pulse oximeter reading, our breath sounds, treat underlying causes of the injury. Be ready with the positive pressure ventilation. If your patient needs it, don't withhold it. Know that positive pressure ventilation can cause that simple pneumothorax to go tension. So we need to reassess, and call ALS to meet us and pop a needle in a chest. As we start to provide positive pressure ventilation, we're thinking ahead to complications that can arise and how we're going to resolve those, or how we're going to respond to those. Maybe when it reaches the point that you have to provide positive pressure ventilation, my patient this hasn't gone tension yet, and my patient hasn't decompensated yet, but knowing that there's a high risk of that with positive pressure ventilations with this developing pneumo, that could be the time to go ahead and call for ALS rendezvous to meet you along the way so that they can pop a needle in that chest. Okay, we've talked about what tension pneumo is. You have a simple pneumo and you have continued accumulation of air in the pleural space, and eventually that accumulates to the point that it starts to impact the mediastinum. And that mediastinum is pushed away from the simple pneumo, and as that pushes away, you start to see a decrease in cardiac output. That leads to shock because cardiac output is compromised, and ultimately, if left untreated, it will result in a dead patient. This one, no. Signs and symptoms: chest pain, tachycardia, marked respiratory distress, absent or severely decreased, lung sound on the affected side, hypotension, altered mental status, JVD, cyanosis, tracheal deviation. Let's draw a line between cyanosis and tracheal deviation. I'll come back to it in a minute and tell you why. Do they have to have all of these every time to have a tension pneumo? No. If you're seeing that progress and you're seeing more and more of these, then that is going to give you an index of suspicion that your patient is developing a tension pneumo. Tracheal deviation, if I had the ability on this slideshow right now, I would draw a circle around that and I'd put an arrow over here and I would write rarely seen. And I've talked to, and it does happen, I have talked to a few clinicians, including doctors, who have seen tracheal deviation with the tension pneumo, but it's rare. We look for it all the time because in that rapid trauma, what do? Is the trachea midline? That's why we want to know, is the trachea midline, or is there JVD and a deviated trachea? Maybe that patient they had a car wreck and it was the middle of the night on a desolate road and it's been 4 hours since the wreck and their pneumothorax has progressed to the point that it's a tension pneumo, and then that's getting worse and worse. And then we drive up on the scene and we start our rapid trauma and boom, there's jugular veins bigger than our patient's thumb and the trachea isn't midline anymore. The tension pneumo, the trachea is going to deviate away from the side of the pneumo. That should be obvious at this point. We used to make a big deal of that. And we'd have test questions. The tracheal deviation in a patient with a tension pneumo is A, toward the side of the injury, B, away from the side of the injury, never happens, is impossible, or something like that. And D, I don't know what that choice would be. We used to make a great big deal of that because the book did, and clinical experience taught us that we see that late in the game. And if we see that, we're seeing almost all of these other things. So how do we manage that? Request ALS while you're getting your positive pressure ventilation equipment out. We start positive pressure ventilation. Why do we call for ALS? So they can do a pleural decompression or a needle decompression. And it may be that you don't even have ALS available, or you can get your patient to the ED faster than, we're not talking the little blue pill ED, emergency department. You can get your patient to the emergency department, providing positive pressure ventilation and ongoing assessment and intervention for whatever else is going on with them. You can do all of that and get them to the ER faster than you can get ALS to your scene. Then ALS is not a consideration at that point. Document why ALS wasn't engaged, document your transport time, and document ALS response time to your scene or to rendezvous with you on the way to the hospital, and just show why you went directly to the ER providing BLS care. And be sure and tell when you give report in the ER, tell them why you chose to transport and provide the treatment you did rather than wait for ALS, because they're going to expect that you should have waited for ALS. But we're not going to wait around and decrease our patient's time to receive definitive care. Okay, that's just another picture of what's going on there. Hemothorax is blood accumulating in the pleural space. You see this a lot with penetrating trauma. Somebody shot through the chest 3 times or stabbed with an ice pick in excess of 100 times. I had one of those, and they told me when they did the autopsy of my patient that the forensic pathologist who did the autopsy stopped counting ice pick wounds at 150. But I don't know. I think they would keep counting. I think they would want to get a total count, but maybe not. Maybe they were in a hurry. I don't know. Had to go eat lunch. I've watched them do an autopsy with one hand and eat a sandwich with the other, though. So don't recommend that either. Hemothorax is just air. Hemopneumo, you have air in the pleural space, and you also have blood accumulating in the pleural space. If we were to percuss that patient's chest wall, remember how the doctor puts a finger across the chest and thumps on it with 2 more? What would we expect to be different about the area where there's air versus the area where there's blood? You have hyperresonance. It rings like a drum when you tap on that area where there's air, and then you tap on the area where there's a bunch of blood, and it's kind of a thud. It doesn't have a ring to it like tapping on a finger on top of a drum head. Hemothorax, shock without obvious external bleeding or apparent reason for shock. You need to consider hemothorax. You need to also consider internal bleeding in the abdomen. Could be both. You will see both if you spend very long working in the field in EMS. And decreased breath sounds on the affected side, yes. One second. Make sure that wasn't a text from one of you guys. Nope, it says if I'm suffering from chronic pain, arthritis, stress, insomnia, that CBD gummy bears can change my life. Okay, that's nice to know. Okay, pre-hospital treatment for hemothorax is rapid transport. Hemopneumothorax treatment in pre-hospitally is rapid transport. So now let's talk about cardiac tamponade. We're sliding down to the last 15 slides of this slideshow. So unless I hear objections, we'll blast on through this and not take another break. Pericardium is that fibrous sac that surrounds the heart. And normally there's just, so that you have your, anyway, that there's, in that pericardial sac, between the pericardial sac and the surface of the heart is a tiny amount of, we'll call it pericardial fluid for want of a better term right now. Come back for paramedic school and we'll teach you a different term. But pericardial fluid, what is its purpose? Its purpose is to provide lubrication so that you don't have a friction rub between the heart muscle itself and the pericardium. So that should be just a normal, smooth, gliding expansion and contraction. But if there's trauma, or if there's disease that causes fluid to accumulate in that or blood to accumulate in that pericardial sac, then as that accumulates and it increases, stroke volume goes down because the heart is being compressed and the ventricles are being compressed. If you remember from the human body chapter, we talked about something called Frank Starling's law. Frank Starling's law, the further you stretch the ventricles by filling them with fluid, preferably blood, the further you stretch the ventricles, the harder they contract, or the more stroke volume that the heart has. That's Frank Starling's law. Now let's think about it backwards. Let's think about that pericardial sac filling up with blood, and that compresses the heart, and we don't get as much ventricular refill during systole, so stroke volume goes down, cardiac output goes down because of Frank Starling's law. Now let's watch a quick video about Beck's triad. Pay attention to what the 3 points of Beck's triad are, and then there's description of stroke volume there.
Hey everyone, welcome to Marvel Medicine. My name is Dr. Chaudhry. This lecture is about cardiac tamponade. This is a huge topic on the USMLE where they can ask you tons of questions. The first thing I want you to do is to visualize it. Imagine the heart, the ventricles, atria, and imagine the way it fills during diastole and contracts during systole, like a balloon. Now imagine the pericardial sac, a circular sac surrounding the heart. Try to get an understanding about the compliance of this sac. It's not very compliant at all. Well, what does that mean? It doesn't expand much. It's not stretchable. If you want to understand compliance better, check out the lecture here. Now that we have those images visualized, imagine a pericardial effusion. Imagine fluid surrounding the heart in this sac. If there's a lot of fluid and that sac isn't very compliant, the sac will fill, right? Now, if that sac is filled, do you think the ventricle has room to expand during diastole when it's filling? Nope. The amount of room it has to expand and fill reduces. So what do you think it does to the end diastolic volume? Goes down. So what happens to stroke volume? Goes down. Do you see how you can expand and extrapolate information? What do you think would happen to your blood pressure? Decrease. The other thing they love testing is the concept that the pressures inside the four chambers equalize. What does this mean? Imagine the heart with the fluid around it. Now imagine the ventricles and atria trying to fill up during diastole and expand. Notice that they really can't because the fluid is blocking them. Since that fluid is surrounding the heart all around, each chamber won't be filling differently. It will fill the same around, meaning the diastolic pressures will be the same. This is a huge giveaway. The discussion of tamponade also leads to the discussion of pulsus paradoxus. What you need to know is, in normal conditions with inspiration, your blood pressure will decrease, but not by much. Pulsus paradoxus is when the blood pressure decreases more than 10 millimeters mercury. Why does this happen? Visualize the heart. Now imagine inspiration. What does that do to interthoracic pressure? It decreases, right? Negative pressure acts like a suction or vacuum of sorts. With this negative pressure, venous return increases to the right side of the heart. If a patient has tamponade, and now more blood coming back to the right atrium, that means more blood going down to the right ventricle. Now, once all this blood gets there, the ventricle will want to expand, right? Well, on the lateral side, it can't expand because the fluid is blocking it. But look at the septal side. What happens is that the increased preload causes the septum to kind of curve in. When that happens, what do you think happens to the left ventricle's volume? It decreases. So what happens to stroke volume and cardiac output? Decreases. That's why you have the exaggerated drop in blood pressure.
Okay, so we've covered that now. Beck's triad. It didn't talk about Beck's triad, and I said it would. Okay, jugular venous distension. Why? Because we have decreased left ventricular output, which causes blood to back up, for want of a better term, blood to back up through the pulmonary veins. Remember, pulmonary veins carry oxygenated blood away from the lungs, backs up through the pulmonary veins and into the capillary beds of the in the alveoli. Then that congestion, or that blood that's not moving through properly, that pushes pressure back to the right ventricle. What does the right ventricle do? It pumps blood out through the pulmonary arteries out into the lungs, right? So if that right ventricle has blood backing up in it, then that backs blood up into the right atrium, which then backs blood up into the superior vena cava. And remember, the superior vena cava is that large vein that all of the veins of the upper body empty into, including the jugular veins, which are the veins that move deoxygenated blood from the brain back down to the heart. So as this compression increases and it starts to interfere with that right ventricular output, that's going to interfere with right atrial systole. That's what I meant by output. And then that backs up to the point that you see this humongous jugular venous distension. Muffled heart tones. How do I know what muffled heart tones sound like? You need to listen to a lot of hearts to hear what normal heart tones sound like. Why would they be muffled? Because sound does not travel as well through liquid as it does through air. So muffled heart tones, because the sound of the valves opening and closing in the heart are muffled by all that fluid in that pericardial sac. And then you saw how the narrowing pulse pressure works. That's the systolic and diastolic pressure getting closer and closer until the point that there's not enough difference to be able to move blood into the ventricles and out through the ventricles. It's exaggerated on inspiration. Really, this is, other than if we see a gross change in systolic and diastolic blood pressure, a gross change in pulse pressure. By gross, I mean great big, not something that makes you want to go throw up. But if we see a gross change in pulse pressure, we can assess that pre-hospitally to get a really good indication of that fall in systolic pressure. You either have to, well, it's really hard to do pre-hospitally. It works better if you have some sort of hemodynamic monitoring in place, some more invasive, but know that those are the three. That is Beck's triad: jugular venous distension, muffled heart tones, narrowing pulse pressure. If you have those in the scenario on a chest trauma question, then your answer is going to be cardiac tamponade. And then of course, going to have altered mental status because cerebral perfusion is in the dumper because systolic blood pressure is going down. So not moving as much oxygenated blood out of that left ventricle during systole. So cardiac output goes down and mental status is going to follow cardiac output, meaning if one goes down, the other does. What is our treatment pre-hospitally? We're going to support ventilations and rapid transport, ALS intercept / rendezvous, whichever you want to call it, or air medical to our scene. Rib fractures are very common in older people. This is a big killer eventually in old people. So let's say our old person does not develop a pneumothorax or a hemothorax or a tension pneumo or a hemopneumothorax. Our old person just stands up, gets dizzy, falls on the corner of a table, fractures ribs, and then 3 months later they die. Why do they die? Have fractured ribs, so they underbreathe. They're not, if you've been around old people, they're not the most compliant patients in the world. If it hurts, as my mother-in-law said back when she was still with us, I ain't gonna do it. And if Melvin McCowan said I ain't gonna do it, it wasn't gonna happen, because and I mentioned that my mother-in-law about 11 o'clock one night stood up suddenly. That caused her to become dizzy, and she fell and she landed on a table and broke 4 ribs in one place on each rib. She didn't have a flail segment, none of that. She just had 4 stable, simple rib fractures. And when my brother-in-law called me about 2 hours later and woke me up at 1 o'clock in the morning and told me they were in the ER and she'd fallen and she had 4 fractured ribs, in my mind, I thought right there, and I didn't say this to anybody else, but in my mind, I thought this is the beginning of the end. And what happened? She would not do her deep breathing. They could not force her to use that spirometer, that inhalation spirometer, so that she was actively breathing deeper and moving all the air she could deep down into her lungs and expanding them. And what happened? Eventually, she developed pneumonia, and that pneumonia progressed and it didn't respond well. And eventually that pneumonia caused respiratory failure. And she was a DNR patient, and that she didn't want a bunch of extra stuff done. She was 94, and as she said, she was ready to go home, and she did her part to make sure of that. I'm not talking going to the house, go home. She was ready to go to her eternal home. She was tired of fighting, and she just slowly decompensated over a matter of a couple of months and passed away. Rib fractures, localized tenderness and pain during inspiration and expiration. Sometimes anything that causes that chest wall to move hurts. They can point with one finger where it hurts the worst. Rapid, shallow respirations, the body's going to do what it can to keep minute volume up. So we have decreased tidal volume. That's all right. The body says we'll just increase the rate of respirations, and that is what happens. And if they can reach it to do it, they will splint or use their arm and kind of put it right over where the fractured ribs are, or that side of the rib cage, and kind of take the other arm and support it and hold down and hold pressure on their chest to try to stabilize it or splint it themselves. We call that guarding or splinting. Pre-hospital treatment, supplemental O2, transport and position of comfort, unless the mechanism of injury raises an index of suspicion of a spinal injury, and then we're going to engage spinal immobilization. Okay, flail chest. We already saw that video. And I said 2 or more consecutive ribs fractured in 2 or more places. And that's what we have pictured over here, where the rib fractures are. That little piece in the middle that becomes a free-floating piece is called the flail segment. And during inspiration, when the rest of the chest wall goes out, that sinks in. Could have a rib fracture with here, just have costochondral separation. Remember when we talked about people who do chest compressions for the first time say, I broke every bone broke every rib in their chest. No, you popped these costochondral cartilages where this cartilage articulates with that rib. See, these ribs don't directly articulate with the sternum. They articulate with a short piece of cartilage, and could create a flail segment by separating 3 consecutive pieces of costochondral cartilage and then having rib fractures further around that costal arch, which could lead to a flail segment, right? That detached portion moves in during exhalation, moves out during inhalation. That's called paradoxical motion. Your book says that's a late sign of a flail segment. And we already watched the video of it. How do we manage that? Maintain the airway, provide respiratory support. What does that mean? Positive pressure ventilation. Supplemental oxygen along with that positive pressure ventilation. If you're finding a flail segment and you have that paradoxical motion, according to your book, that's a late sign. So as soon as you see that, don't wait around to see how things progress. See if they go downhill. Let's get on that positive pressure ventilation and treat that appropriately. And then provide your ongoing assessment. In the old days, we put sandbags on that to keep that chest wall from moving so much. What did we find? We just put pressure on there to the point that that flail segment didn't move, but we kept it pushed down onto the lung, and that caused compression of alveoli, which decreased ventilation, which subsequently decreased respiration. So our patients did not do well. Finally, some genius, I say that seriously because for years in the ER or out in the streets, we used those dang sandbags on that, or we'd tape it up to the point that it wouldn't move, and we were compromising our patients. And some, probably a bright med student with some common sense said, why are we doing that? Let's do some research. Let's give dogs flail chests, and let's treat some of them with sandbags and some of them without sandbags, and let's see what that does. And they said, see, I told you, all you genius clinicians, we don't need to be messing with those. Just let's ventilate our patients well. That may be, I don't know that's how that happened, but I can sure picture that. Okay. Always suspect a pulmonary contusion in a patient with a flail chest. It takes significant amount of trauma to cause a flail chest. You just rarely see it. You might see 2 in a year, but you might go 5 more years and never see another one. But suspect a pulmonary contusion. What happens in a pulmonary contusion? The alveoli become filled with blood. That impairs ventilation of the alveoli, that impairs oxygenation, and that compromises our patients. They become hypoxic. So we treat that again with positive pressure ventilation. We're going to, with 100% O2, we're going to get the best we can out of this and get them to a surgeon or somebody who can fix this stinking thing. Sternal fractures, rare, but that should give you a high index of suspicion of maybe pericardial tamponade, maybe pulmonary contusion, maybe injury to the great vessels, maybe we're going to be watching for a hemothorax, going to be watching for a pneumothorax, tension pneumothorax, all of those things, because we can't see what's going on inside. Oddly enough, we can sometimes pre-hospitally now, because the price of pre-hospital portable ultrasound has gone way down. We're talking $400 to $1,000, and you can do an ultrasound and you can see blood, you can see fluid in the chest, you can see air in the chest. You have to know what normal looks like, but we do have a way to see what's going on inside now. It's not as common as it should be because it's $1,000 or $2,000 for a good one. So, but you can use it in all kinds of places. You just don't use it every day. You can charge for it when you use it, but you don't use it every day. So we just still depend on our normal senses as clinicians to recognize and treat this stuff. Okay, traumatic asphyxia. This is probably a post-mortem, meaning after she's dead, picture. What do we note that's different about this dead person than we might expect to see in another dead person? Well, this skin color up here above the clavicles and in the neck and face and around the eyes don't match this skin color down here, huh? Well, I wonder what happened. Let's talk about Perthes syndrome, which is traumatic asphyxia. We have massive blunt force trauma, and this is, there's still a little cross hanging around her neck. I hadn't noticed that before. Probably this is where a chest tube was. But what happened? We had massive blunt force trauma to the chest. And what we're seeing here, and what you will see, some people call this purple head syndrome. That's what I always called it. It was just a few years ago that Perthes syndrome became part of my vocabulary, and it's still not there very well because I can't pronounce that word right. Perthes syndrome, I don't know. Distended neck veins, cyanosis in the face and neck. That's worse than cyanosis. That's purple. That is not blue. Hemorrhage in the sclera of the eyes. So the whites of the eyes have hemorrhages. You see like the whole sclera is redded out, just red where the whites of the eyes should be. We have a sudden severe compression of the chest. Times that you'll see this, times that I've seen this, that I absolutely remember for sure. Somebody working under a vehicle and not using jack stands, just have a jack under a vehicle, or they have concrete blocks or bricks or something stacked up. And I've seen that where it becomes unstable, it falls off the jack, or it falls off of the wood that's stacked up. You'd be amazed at what people use to try to prop a vehicle up when they're underneath it working, and that vehicle falls on them, and boom, you have some vehicles like 5,000 to 6,000. I think my Dodge diesel pickup its weight is like 7,500, and you have that just boom all of a sudden coming down on the chest, and you have that extreme sudden compression of the chest, and you have injury to the heart, you have pulmonary contusion, and it also forces. So what causes that purple color of the skin and those hemorrhages in the whites of the eyes and the sclera and the conjunctiva? It's blood going the wrong way. That compression of the chest forces blood up through venous circulation and forces it backward into capillaries and arterioles, and that blood being forced backward through the system is what causes that purple head appearance and that blood in the sclera of the eye. So now that we've talked mechanism of injury as well as the pathophysiology of what's happening, now it's easier to understand why this patient has that purplish head, right? This is some massive trauma. When you see this, these patients do poorly. I'm sure there are patients out there who survived this. I can't remember any. Just because in my 39 years I haven't seen one survive doesn't mean they don't live every day. Just not the normal occurrence. Okay. And then in your medical emergencies semester with me in paramedic school, we'll talk about this in a medical situation also, and what can cause this medically. And then pre-hospital treatment, ventilatory support, supplemental O2, monitor vital signs, probably do CPR, immediate transport. Blunt myocardial injury, bruising of the heart muscle itself. Your patient may have an irregular pulse. They may have difficulty maintaining good systolic blood pressure because the myocardium's injured and it's not pumping correctly. Also, remember the electrical side. We may have damage to the electrical side of the heart, or this trauma to the myocardium may trigger those ventricular cells to start firing off electrical impulses at the wrong time or on their own. And in paramedic school, we'd say that you're likely to see PVCs or premature ventricular complexes, possibly ventricular tachycardia, and ventricular fibrillation are, that should say not uncommon, I think, because that is something that you could see. And then chest pain and discomfort, severe blunt force trauma to the chest. We need to be keeping an eye on the rate and rhythm of the heart as we do our pulse checks. And we need to contact ALS because they have extra tools to use. In the meantime, we could begin rapid transport, provide supplemental oxygen, keep careful watch on trending those vital signs, including not just the rate of the pulse, but the regularity of the pulse. Have your AED. You don't have to have the pad stuck to the chest already, but have that AED handy and ready to go if you need it. And last but not least, commodio cordis. I mentioned this when we talked about the cardiac emergencies. Remember, I said that this is caused by a sudden direct blow to the chest. Quite often you see this with sports injuries. You have a perfectly healthy person rocking along, everything's great. The little league pitcher delivers a pitch to home plate. It's a perfect 43-mile-an-hour screaming fastball hit right back up the middle by some great big giant kid who looks like he needs to be in high school, but he's still in little league. And he hammers that line drive straight back, hits the little pitcher in the chest, and boom, he drops immediately in cardiac arrest. Why? Because in the second half of the time of the ventricles repolarizing, remember I was talking about the electrical activity coming through the heart. That's what makes those waves for the tracing of an EKG. It's measuring electrical activity. The big hump at the end of the complex represents the ventricles repolarizing and getting ready to be stimulated so they can fire and contract again. And the second half of that is a very crucial time called the relative refractory period. And if you have an extra heartbeat happen, you have a PVC that I mentioned earlier, you have one of those, you have electrical impulse at the wrong time, an electrical shock in that second half, that relative refractory period, or that baseball hitting that chest, that releases an electrical impulse. And if that hits in that time, that second half of the time when the ventricles are repolarizing, it can immediately put that patient into ventricular fibrillation or non-perfusing ventricular tachycardia. How do we treat that? We learned that the second class period of this course. Oh yeah, we apply electricity, right? We use the AED. This could be a hockey puck. It could be a kick in a martial arts event. It could be anything that's just rapid blunt trauma to the chest in that crucial part of that repolarization can send that person straight into VFib. The good news is they haven't been sick. They're not having a heart attack that causes them to start having these extra funky beats that somehow land in the wrong place. This is a normal healthy person, and defibrillation works well on them. Before we get there, what do? We're going to do CPR. Okay, wait, this got jumbled up. Okay, we're going to do CPR, and we're going to get the AED, and if we can defibrillate them within 2 minutes of that injury, I mean, we're talking way over 90% survival, approaching 100% survival rate of that. So that is commotio cordis. So if you have a scenario of somebody being struck in the chest with a ball or a kick or a punch, I remember high school and guys trading punches to the chest. Holy crap. Talk about risky behavior. That's why they called us adolescents. We did all kinds of stupid stuff. Who knew? Okay. Laceration of the great vessels. This will be our last slide. Rapidly fatal hemorrhage. You have one of the great vessels that's torn, and that person bleeds out like right now. And every time we try to pump blood, they bleed out more. Pre-hospital treatment includes CPR. Why? We're pumping all the little blood they have left out into that mediastinal area. That's all the treatment we have. We're going to try CPR. It's probably not going to work, but we're going to try it. We're going to provide ventilatory support with oxygen, immediate transport. Be alert for shock, because if you have laceration of one of the great vessels, they are going to develop hemorrhagic shock. Get a good set of vital signs if they have any, and then trend those changes as you reassess and get them to the hospital. And maybe by some miracle there is a vascular surgeon nearby, and that vascular surgeon can work with the cardiothoracic surgeon. Surgery involves a good deal of vascular surgery too, just like we saw with doing coronary artery bypasses and plumbing around those occlusions in coronary arteries. So cardiothoracic surgeon, they can do enough vascular surgery to try to fix this if we can get our patients there alive. Maybe our patient just has a slow leak and they're able to fix this at the hospital. Quite frequently, this mechanism of injury is significant enough that vascular surgeon's probably not going to do them any good, but we can always hope. All right. Questions about any of that stuff? All right. The exam will only be over one chapter. Had a bunch of work to do around the house, and I did not